Good morning, everyone. Today we are going to study about the antidepressant drugs. So these drugs used in the condition of depression, bipolar disorders, and unipolar disorders. So this is the diagram where you can see a person is sitting down in a sad condition. So, what is depression? Depression is associated with the feeling of sadness, loss of interest, self neglect, anorexia, sleep disturbances, and suicidal feelings. So, there are some hypotheses uh, behind the pathogenesis theory of the depression. So these are there are three hypotheses actually. So first one is more recognized, so that is known as the monoamine hypothesis. In this hypothesis, there is deficiency of monoamines, that these are 5-HT or serotonin, norepinephrine, and dopamine in the cortical and limbic systems in the brain. So this causes the depression. Another theory is neurotrophic hypothesis. There is a decrease in the brain of there is a decrease in the brain derived neurotrophic factor. This is BDNF. So BDNF actually controls the neurogenesis. If there is deficiency of this factor, so it causes the depression. Third one is some abnormalities in the HPA axis, thyroid functions, and sex steroids level causes depression. So now we have the some classification of the drugs. So first one is the selective serotonin reuptake inhibitor. So these are also known as the SSRIs. So these are fluoxetine, fluoxamine, citalopram, escitalopram, and sertraline. Second one is the SNRIs. So the full form is serotonin norepinephrine reuptake inhibitors. So these example of this category are venlafaxine, desvenlafaxine, and duloxetine. Third one is the TCAs. This is actually old one, and this category have many adverse reactions. So this is now not in so much use now these days. So tricyclic antidepressants are imipramine, desimipramine, amitriptyline, and nortriptyline. Atypical antidepressants: bupropion, amineptine, tianeptine, nianserin, and mirtazapine. Serotonin blocker or 5-HT2 antagonist. So these are trazodone and nefazodone. The last category is the MAO inhibitors. So this is monoamine oxidase inhibitors. Examples are phenelzyme, isocarboxazide, moclobemide, and chlorgyline. Now the mechanism of action of SSRIs, selective serotonin reuptake inhibitors. So as the name of this category uh, describe the mechanism, so they inhibit the serotonin transporters, and this blocks the reuptake of the serotonin in the neuron. This increases the availability of the serotonin at the receptors. So thus enhances the serotonergic activity, and there is improvement in the symptom of the depression. So as in the diagram we can see there are two synaptic cells. One is the presynaptic and another one is the postsynaptic cells. In the postsynaptic cell, there are serotonin receptors, while in the presynaptic cells, there are subvesicles and serotonin channels. So in the serotonin vesicles, serotonin stores, and in time to time it ruptures and serotonin releases into the synapse. After some time being in the synapse, it actually uh, goes inside once again into the presynaptic cell through serotonin channels. So our drug SSRI actually blocks the reuptake of the serotonin, which increases the amount present in the synapse and thus magnifies its effect. So this is all about this. So the features of the SSRIs. So it has no anticholinergic effect, no hypotension, no weight gain, no sedation. It don't precipitate the convulsions, don't cause the arrhythmias, and it is actually orally effective. Now the adverse drug reactions. So these are the gastrointestinal symptoms are the more actually. So these would be nausea, vomiting, diarrhea, etc. Some other ADRs are headache, insomnia, sexual dysfunction, impotence, and it can cause also the loss of libido. Now, the another category is the SNRIs, serotonin norepinephrine reuptake inhibitors. As the name it suggests, that it inhibit the serotonin transporter and norepinephrine transporter. It inhibits the reuptake of the serotonin and noradrenaline in the neuron. Increase the level of serotonin and noradrenaline in the receptors, and that increases the serotonergic and noradrenaline activity in the brain, and depression improves. So the main drugs are venlafaxine and desvenlafaxine. The both drug inhibit both the transporters. One is the SERT, another is the NAT. What is the actually difference in between this? So actually, these drugs inhibit the serotonin transporter 5 times more than the norepinephrine transporter. So this is 5 times more potent. So another diagram what we have, as you can see, the um, bluish bar is it denotes the serotonin, green bar denotes the noradrenaline, while the yellow bar denotes the venlafaxine, SNRI. So in the one neuron there are some vesicles, so which is filled with the serotonin, and in time to times these vesicles ruptures and the serotonin releases in the synaptic cleft, and actually it goes to its receptor, which is situated on the postsynaptic membrane. And with the time, it actually the serotonin actually goes inside to the presynaptic neuron through the serotonin reuptake transporters. So as you can see, our yellowish bar, or you can say the drug SNRI, blocks the serotonin transporter. So through this mechanism, there is availability of the serotonin properly in the synapse, and it properly uh, in the sufficient quantity, it uh, goes to the particular receptor in the postsynaptic membrane, and uh, it completes the cycle. And the same condition is there with the noradrenaline receptors. So our drug SNRI actually also block the noradrenaline reuptake transporter in the another neuron you can see. So there is availability of the noradrenaline properly in the synapse, and it finally goes to its receptor and binds there and causes the proper effect. And through this mechanism, the depression improves. Features. So SNRI, these drugs don't have anticholinergic effects. Uh, they don't have postural hypotension. They don't have weight gain quality. They don't have sedation property. They don't precipitate convulsions, and they are actually orally effective. A lot of tablets are available about this category. So adverse reactions are nausea, sweating, anxiety, sexual dysfunction, and sometimes hypertension can also occur. The third category of the drugs are tricyclic antidepressants. So they inhibit the serotonin transporter and norepinephrine transporter. So inhibit the reuptake of the serotonin and noradrenaline in the neuron, and thus increases the level of the serotonin and noradrenaline noradrenaline at the receptors and increases the serotonergic and noradrenaline activity. So the mechanism of TCA is actually just same as the SNRI category. So as you can see in the diagram of mechanism of action of tricyclic depressant, we have the presynaptic neuron and the postsynaptic neuron. And from the vesicles, the serotonin and the norepinephrine, uh, it releases into the synapse, and some quantity goes to the receptor and bind there, but some quantity actually re uptaken from a particular transporter. So our TCA, the drug, actually blocks this transporter. So there is proper availability in the of serotonin and norepinephrine in the synapse, and the sufficient quantity binds to the particular receptor in the postsynaptic neuron, and the mechanism completes. So the ideas of the tricyclic antidepressant. Tricyclic antidepressants are actually older category of the antidepressants. They have actually a lot of adverse drug reactions. So now these days we don't prefer actually TCS. We prefer SSRI actually and SNRI somewhat. So the ideas of the TCS. So they have anticholinergic effects like dry mouth, constipation, blood vision, urinary retention. They have also alpha receptor blockage property, so it can cause the postural hypotension or orthostatic hypotension. They can cause the arrhythmia, tachycardia. They can weight gain due to increased appetite. H1 receptor blockage property also they have, so it can cause the sedation and confusion. And the last adverse reaction is the lower seizure threshold they have. So it can precipitate the convulsion also. Contraindication of the TCS in the condition of glaucoma, epilepsy, ischemic heart disease, and benign prostatic hyperplasia, we don't use the TCS. Otherwise, these conditions can be more harmful. Another category is the serotonin blocker, 5-HT2 antagonist. So they inhibits the reuptake of the serotonin through blocking the serotonin transporter. So these are actually 5-HT2 blockers. So drug are trazodone and nefazodone. Trazodone, the ADR especially, it has postural hypotension, priapism due to blockage of the alpha adrenergic receptor, while nafazodone has sedation, hepatotoxicity, and mild postural hypotension ADRs. So use with caution. Another category is the atypical antidepressants. So the drug is bupropion. The mechanism of this drug is it inhibits the reuptake of the dopamine and noradrenaline into the neuron. So thus increases the availability of the dopamine and noradrenaline into the synapse. So thus enhances the dopaminergic and noradrenaline activity in the brain. So you can see in this diagram also. So bupropion inhibit both the transporter, dopamine and noradrenaline or norepinephrine transporter. So depression improves. Features of this category. It is useful for smoking cessation, no anticholinergic effect, no hypotension, and no sedation. ADRs, insomnia, agitation, dry mouth, sweating, tremors, and convulsion can be possible. Another drug is mirtazapine. Mechanism is it blocks the 5-HT2, 5-HT3, and alpha receptors. It thus enhances the release of serotonin and noradrenaline. Adverse reaction can be sedation and weight gain. Another drug is neanserin. It blocks the presynaptic alpha receptors. So increases the noradrenaline release. First reactions are sedation, anticholinergic effects, cardiac side effects, precipitate the seizure, epilepsy can be possible, blood dyscrasias and liver damage. Last category of the antidepressants is the MAO inhibitors, monoamine oxidase inhibitors. So we have some categories in this part. So classification of the MAO monoamine oxidase inhibitors. So we have reversible and irreversible, both types. So first we see the irreversible MAO inhibitors. So these are selective MAO A inhibitor like chlorgyline, selective MAO B inhibitor, selagiline, non-selective MAO inhibitors are tranil, cypramine, isocarboxazid, and nialamide. While in the reversible inhibitors of the MAO A, so it is also known as the REMA. So these are moclobemide and brofaramide. MAO inhibitors. Irreversible MAO inhibitors are selective MAO A inhibitor and non-selective MAO inhibitors. So they can cause the cheese reaction also. REMA actually do not cause the cheese reaction. Location and use of their inhibition. MAO A inhibitors, they cause the peripheral adrenergic nerve endings. They are actually available at the peripheral adrenergic nerve endings, intestinal mucosa, human placenta, and in the liver. So they actually the MAO A inhibitors actually used in the condition of depression, while the location of MAO B is in the liver, certain areas of the brain, and in the platelet. MAO-B inhibitors used in the Parkinson's disease. MAO inhibitors mechanism, exact mechanism. So monoamine oxide is actually an enzyme. So what is the basic phenomena about this enzyme? So this enzyme metabolizes into monoamines. So these are three things: serotonin, norepinephrine, and dopamine. So our drug that inhibits this are MAO inhibitors. Monoamine oxidase inhibitors. The mechanism. So it is, as you can see in the diagrams. So in the first diagram, normal monoamine of transmission. So the MAO, actually you can see the presynaptic and postsynaptic neurons, and there is a synaptic cleft. So in the presynaptic neuron, there is a synaptic vesicle into there is MAO actually situated, and actually it the MAO inactivates monoamines, norepinephrine, serotonin, and dopamine that leak from a synaptic vesicles. And finally, it goes to their receptor, which are situated on the postsynaptic response. So in the diagram B, you can see the effect of monoamine oxidase inhibitors. So MAO inhibitors prevent the inactivation of the monoamines within a neuron, causing excess neurotransmitter to diffuse into the synaptic cleft. Mechanism of action, as you can yeah, see the diagram, and on this on the based of this there is interpretation about most monoamine oxidase inhibitors such as phenelzyne from stable complexes with the enzyme causing irreversible inactivation. These drugs inhibit not only MAO in the brain but also MAO in the liver and gut that catalyzes oxidative deamination of the drugs and potentially toxic substances such as tyramine, which is found in certain foods. The MAO inhibitors therefore show a high incidence of drug-drug and drug-food interactions. Now, what is cheese reaction? This is something important. So, when a patient of depression is getting the treatment of monoamine oxidase inhibitors, these could be selective MAO inhibitors and non-selective MAO inhibitors. And when this patient eat or take the cheese, fish, meat, beer, wine, or yeast, which are rich in tyramine, there is possibility, and especially there it occurs actually, the hypertensive crisis and cerebrovascular accident. So this known as the cheese reaction. So why this happens? Because the tyramine actually metabolizes by the MAO, monoamine oxidase enzyme, and into the gut wall and in the liver. But if the monoamine oxidase inhibitors are used, so what happens to this tyramine? It do not metabolize and it reaches to the systemic circulation where it displaces the noradrenaline from the nerve ending. And due to increased level of the noradrenaline, there is hypertensive crisis, and cerebrovascular accidents. So this is something very serious and emergency condition where you have to treat this emergency. Now we have the ADRs of the irreversible monoamine oxidase inhibitors. So these are cheese reactions, orthostatic hypotension, weight gain, restlessness, insomnia, anticholinergic effects, and serotonin syndrome. What is serotonin syndrome? So when a patient of depression takes the SSRI along with MAO inhibitors, so there is significant increase in the level of serotonin because both inhibit the reuptake of serotonin. So a lot of serotonin is available in the synapse and it binds to the receptor. So there is serotonin. So this is serotonin syndrome. So the symptoms are hyperthermia, restlessness, sweating, muscle rigidity, aggressive behavior, tremors, seizures, coma, and it is actually it can be fatal. Now the mechanism of reversible drugs. So these are moclobemide. It don't or incompletely inhibit the intestinal monoamine oxidase. Due to competitive inhibition of the MAO, taramine competes with the moclobemide. Taramine and moclobemide mechanism of action. Taramine displaces the moclobemide from the active site of the MAO enzymes. So MAO metabolizes the taramine in the gut wall. And advantage of REMA, it has there is no or lesser chances of the drug interactions and hypertension. So this is much safe. It do not cause the cheese reaction. Due to reversible and short action, it is more safe because full MAO activity is restored within 1 to 2 days after stopping the drug. It is also devoid of anticholinergic, alpha receptor blocking, and sedative effects. So adverse reactions are very less. Uses of depression now we have, and uses of antidepressants. So these drugs can be used in the condition of endogenous depression, anxiety disorders, psychosomatic disorders, panic attacks, and in the obsessive compulsive disorders. Smoking withdrawal, premenstrual syndrome, bulimia nervosa, and nocturnal aneurysms. Now, the drugs for the bipolar disorders or manic depressive illness. So, it is a psychiatric disorder, depression alternates with mania. So, what is mania? Mania is agitation, hyperactivity, uncontrolled thoughts, and speech. So the drug used in the condition of mania is lithium. So lithium, the mechanism is lithium reduces the release of inositol triphosphate and the DAG. So this improves the condition of mania. DAG is second messenger for the alpha adrenergic and muscarinic transmission. Pharmacokinetics. The lithium absorbs orally well, it distributed through the body water and not bind to the plasma protein. It is not metabolized, excreted in the urine, saliva, and sweat, and it has low therapeutic index. It needs the therapeutic drug monitoring. So be careful when you treat the patient of mania with lithium. Uses. It is the first drug for acute mania. Prophylaxis for the bipolar mood disorders we can use, and in the condition of depression also. Adverse reactions of the lithium are more. So these are nausea, vomiting, diarrhea, tremor, ataxia, drowsiness, and slurred speech can be possible. Polyuria and polydipsia also occurs. Acute lithium toxicity. If it occurs, then the treatment is we have to stop lithium immediately. We have to inject the mannitol, and we can use the intravenous infusion of normal saline. And if there is a need, so we can use the hemodialysis also. Other drugs in the mania and bipolar disorders. So little bit, these are some miscellaneous drugs we can also use in the little bit condition. So these are sodium valproate, carbamazepine, topiramate, olanzapine, and benzodiazepines. So this is all about depression. Thank you.